Excellent. Okay. Hi. Feels a bit weird, doesn't it? Okay, so we have started our little online session. So welcome everybody. Thank you very much to Dean for giving up his time for this. He's such a lovely man and father to be. There you go. For letting me know all about this, because obviously we know this is a huge issue and in the Kimberley region, and this man is an extremely busy man. Just came back from Luma yesterday. So he travels around the countryside with his job with the Kimberley Renal Centre. Hi to everybody that's tuning in from around the Kimberley or wherever you are, and those big number of people that are tuning in today. So thank you very much. And handballing it to Mr. McKittrick.
Okay. Thank you, everyone. Thanks for coming. My name's Dean. I'm one of the renal GPs. I'm a general practitioner with advanced skills in emergency medicine, but quickly got this job, so I haven't really used my PD skills for a little while. But in the interest of time, I'm going to whiz through it. I wasn't sure what the clientele or the punters that were coming today, so I've kind of based it from everything from student to medical practitioner and everything in between. So it may or may not be applicable to you in certain areas. Just trying to do a catch-all. So we're going to talk about today chronic kidney disease and renal replacement therapy in the Kimberley. So here we go. So the brief I got was dialysis, all about it, how it's done, the lead up to getting a chair, fistula care, the general overview would be great info, and kidney health would also be a great and relevant discussion point. So there's a fair bit to unpack there and now, but I'll do my best. I'll try and whiz through this, but if you have to go at the tail end of it, I won't be offended or anything, just sort of make your way out. I've kind of put the things that are more applicable to everyone at the start, and it gets a bit nuanced at the end, so you're finding it's less and less applicable and you've got to go, feel free. So here we go. So to start off with, I rely very heavily on this resource, and if you don't know about it, I would recommend that you give it a look. This is the Kidney Health Australia Chronic Kidney Disease Management and Primary Care Handbook, released in 2024, so it's very up to date. It's the 5th edition. You literally just Google CKD management. It's the first hit. You go in there and you can download your electronic copy. It's about 88 pages, so it's not the 150 or 80 or whatever it is for diabetes management, which is horrendous. Really good clinical pearls, some flow charts and templates, really, really nicely laid out. That's the dude on the front. If you find him, you're in the right place. So let's just do a little bit of overview of CKD. So why do we worry about CKD? Well, it's common. Over 2 million Australians are currently living with CKD. It's twice as common as diabetes in Australia. 3 out of 4 Australian adults have at least one factor increasing their risk for CKD. 1 in 5 First Nations Australians aged 18 years and over are living with signs of CKD. And if you compare this to the 1 in 10 non-Indigenous Australians, it's a pretty stark contrast. Burden of disease is increasing. The number of CKD cases have doubled in the last 20 years, and it's not really looking like it's slowing down. People with CKD are 20 times more likely to die from a heart attack or stroke than they are to progress to advanced end-stage renal failure. There's around 20,000 Australians die every year with CKD, and the burden of CKD is greatest in low socioeconomic backgrounds, in rural remote areas, and in First Nations Australia, which, I mean, we're ticking lots of boxes there within Kimberley. CKD continues to contributes to 1 in 6 hospitalisations nationwide, and CKD not only has a negative physical effect on your health, but also to your family life and psychosocial health, which we know is equally as important to our patients. Importantly, CKD is treatable. We can slow progression of disease by up to 15 years if we start therapy early enough at the right time. And if detected and managed appropriately, we can reduce up to 50% of renal deterioration before it gets too late. So, kidney disease is often overlooked. Less than 10% of people are aware they have CKD, and late referrals are common. 17% of patients are referred to a nephrologist and commence dialysis within 90 days of referral. That's a nationwide statistic, and we call that crash landing into dialysis. It's pretty scary stuff. 90% of kidney function can be lost before the patient experiences any symptoms of CKD. So you'll find that I'll do a lot of comparisons to diabetes because in some ways it's similar. It's a chronic disease. It's quite insidious. You can have it for a long, long time and feel no different to anyone else in the room until all of a sudden, bang, everything starts to come undone. So, heading back to, we've got a lot of students in here, just 3 in the room. So, what's everyone's background here? We got some medical students. Quick nods, yeah.
Chiropractor, and I've got 5 chiropractic students I'm supporting.
I'll take it back then. You guys can face it. No worries. Okay, so quick definition of CKD. It's a little bit wishy-washy, but I'll try and make it digestible. So it's 2 caveats to it. You can either have an EGFR that's reduced below 60, but it's got to be present for equal to or more than 3 months. So that's a really important point. If it's less than that, it's an AKI. So we need to prove that its chronicity is there. So you can either have the reduced EGFR or evidence of kidney damage without reduced EGFR. And you're kind of going, what? What does that mean? So if you have any form of proteinuria, structural abnormalities on imaging, any biopsy issues, or hematuria after urological causes have been excluded, we would call that CKD as well. I will go into this a little bit more in a graph that makes it a bit clearer about this whole EGFR, normal, not normal, both of CKD. But bear with me, just plant that seed. CKD risk factors, by golly, there's lots of them. So anyone with diabetes, hypertension, established cardiovascular disease, a family history of kidney failure, obese with a BMI above 30, current or past smoker / vapor, that's a new one. History of acute kidney injury, not smoking the vaping, right? History of acute kidney injuries, anyone aged over 60 and First Nation Australians aged 18 years or older at higher risk. So you have a look at that and think about all the people you work with. That's covering a good lion's share of the people and the patients that we deal with on a day-to-day basis are all have at least 1 or 2, if not more, risk factors for chronic kidney disease, which is quite scary. Causes of kidney failure in our community, diabetes and hypertension by far are the lion's share of the graph. 51% of that pie chart is diabetic, hypertensive nephropathy. I like to divide this graph in halves. Side closest to me is what we do at KRS. That's our GP work and our primary health inputs. The other half, the familial, the glomerular, the genetic, the autoimmune stuff, is what the nephrologists and the boffins get really excited about. And that requires specialist input. But you can see just over half of our workload can be done at the primary care level. So that's why it's really important that we're all aware of it and actively participating in management. CKD screening. A kidney check is really, really easy. It's just a blood pressure check, a urine ACR, and that stands for albumin-creatinine ratio, which is just detecting protein in the urine, and an EGFR, so your biochemistry on the blood test. We can get so much information from these 3 basic tests to establish a risk factor and management plan for patients. It's just, that is the mainstay of what we want, the information we want. So going back to our med school days for some of us, we remember that CKD is staged in 5 different stages. Stage 1 to the left of the screen, mild or minimal damage to the kidney, all the way to stage 5 to the far right, which is end stage, needing dialysis. I always tell people that it's like a fuel tank in a motor car. It fills up, it goes down as you get older. There's some things that make you run out of fuel quicker, but the important thing about kidney is you can't refill it. Once you run out of fuel, you're at the side of the road and you're stuck, and that means dialysis or other things. So important to remember, you can go from left to right of the screen, but you can't go from right to left. Once kidney disease has settled in, there's no regeneration of it. That is the number you're stuck with. So this is just a little bit of the story though. So staging is easy enough. 1, 2, 3A, 3B, 4, 5, sure. That sounds pretty straightforward, but it's only half the picture. So if you remember, I was telling you about your EGFR or your glomerular filtration rate, or filtration rate is just the easy way to say it, is it can be normal and it can be reduced into chronic kidney disease. And that's like, what do you mean? That doesn't make sense. I only know it as a reduced kidney function equals CKD. So what I mean by that is, if you only go by this part of the graph, then you can see that things don't look too bad. So this is actually not telling you where your kidney function is at right now. It's telling you the risk of you developing end-stage kidney disease. Green means you've got a very low risk of getting to stage 5. Yellow is a moderate Orange is a high and red is a very high risk of progressing to CKD5. So if you've got a normal EGFR and no protein, low risk. It's a good thing. But you can see you can have a normal EGFR, but as soon as you've got heavy protein in your urine, you're at a high risk of going to CKD5. And that's what I'm trying to get come through here, like with the CKD definition. Doesn't always just mean an EGFR drop. That's only half the story. We had a young lady in Fitzroy Crossing that had an EGFR of greater than 90, but proteinuria in thousands. Some of the highest ACR levels I've ever seen. Within 12 months, she declined all the way down to the bottom of this graph and is on dialysis as we speak. So that's 12 months. So from the end of 2023 to the end of 2024, her kidney function just tanked. And that was because it was poorly controlled diabetes, not engaging with the clinic, non-compliant with medications, not coming in for checks, and it just kind of all unraveled. So again, this colourful chart is not about where your kidney function is at now, it's your risk of how far down the line of kidney disease you get to, okay? So going back to that little Bible I was telling you about, if you do your blood pressure, ACR, EGFR, do your kidney checks, and you work out where your patient is on this chart, that little Bible I told you has all the clinical management plans. If they're in the yellow part of the graph, there it is, it's all there. How frequency you review, what are your assessments, what are you checking in on, what you should be considering. And then you can see it's like a puzzle. So yellow just tacks on a few extra to make the orange, tacks on a few extra to make the red. And it's all there in this really nice book. So for students, it's not so important, it's just about knowing about CKD and risks and managing. But for us practitioners, this is gold. Because I remember sitting there as a GP registrar with a guy in front of me with a low EGFR, and I'm going, what can I do about that? I mean, I've referred to the nephrologist, but what can I do now? And this is where this is going to be very helpful. So, ultimately, we're going to break down that graph or that table into the 5 goals of CKD. We want to slow the decline in EGFR, avoid further damage to the kidneys, maintain healthy blood pressure, lower CVD risks, and reduce albuminuria. So, slowing the decline in EGFR. How do we fight what we don't know about? You need to know the etiology of what your CKD is. The big hitters I've mentioned, diabetes and high blood pressure. If it's still unclear, we get the NEF team involved. We can do a glomerulonephritis screen. We can do renal biopsies. It's all about finding out who your enemy is and fighting appropriately. Then it's just the low-hanging fruit, your lifestyle modifications. SNAP criteria stands for smoking, nutrition, alcohol, and physical activity. So if you can cover those 3-4 things and maintaining a healthy weight, because we know obesity is a high risk factor for CKD, then that's all low-hanging fruit that you can, don't need much training to sort of pass that information on to your patient and slow the decline in EGFR. We do our regular monitoring and our kidney checks that I've let you know about. And with that, we can do additional bloods to make sure that we're fine-tuning things. And that's where us at the renal team can chime in. We can help you address the anemia of chronic disease, acidosis, hyperkalemia, bone mineral disease, muscle cramps, weakness, fatigue, edema, restless legs, and all the other things that go with it. Imagine you've been given this label of CKD, chronic kidney disease, and I tell you, we can't cure it, probably not going to get better. The best we can do is to stop it in its tracks now. That would weigh pretty heavily on your mind, and depending on what number I put with it, if it was a 3 or a 4 or a 5, that's going to have huge ramifications on your mental health. You're given this label. So we've got to bear that in mind as well when we talk to our patients. Avoiding further damage to the kidneys. Well, we're part of the problem with that. So prescribing renally adjusted doses when relevant and avoiding what we call nephrotoxic medications, medications that hurt the kidneys, when our EGFR, our filtration rate falls less than 30. There's also, importantly, sick day medication plans. So sick day, I really don't like the name of sick day medication plans because a sick day is like, I didn't go to school for that cough. You know, like that's not what we're talking about. Sick day, we're talking about you've got horrendous nausea and vomiting and diarrhea, and you're not keeping food down and you're losing fluids and not able to replace it. These medications, SADMANS is the mnemonic for it. All of these medications are ones that will put your kidneys at risk if you're having those sick days.
Avoiding acute kidney injuries. So infections are a big player up here, skin sores particularly, and tonsillitis and things like that. Medications, as I mentioned, and dehydration. And we live in a very hot and humid environment, so dehydration is a big player. And safety netting patients to present and giving them advice about their medications if they do become really unwell. And of course, linking in with the nephrology and KRAS team for support. This is just a little snapshot from that little Bible I was telling you about. It just gives you a handful of things to think about, like, hey, you know, if you get to the orange part of your graph, just bear in mind that these medications are not an exhaustive list, but things to bear in mind that you might need to pull the reins in a little bit if you're charting them, okay? So lowering cardiovascular disease risk. We all know that there's a CVD calculator that we can use and stratify. The new part of the CVD calculator is as soon as you know that the patient has CKD, they go up a step. So even if they've got a low risk on their CVD calculator, as soon as they've got CKD, they go up a step because we know that cardiovascular disease is a huge risk factor for CKD. How I explain to patients is everyone understands that if they've got high cholesterol, they're at risk of a heart attack. That's a pretty straightforward concept, and most people get that through whether it's movies or from people they know or whatever. What I'd like to tell them is the blood vessels in your kidneys are even smaller than the ones in your heart. And if you've got really high cholesterol, what you're causing is a mini heart attack of the kidney. And you're knocking off clusters of nephrons, or the little filter units of the kidney, with your high cholesterol. So treating that is a really, really good thing. There's a new drug called finerenone, which it's there, but we guide it. We use it on the guidance of nephrologists because it's quite a specialised medication at the moment. It's quite new and novel. There's lots of criteria for the PBS to get access to it. You need to be on an ACE, you need to be combined with other SGLT2s and an EGFR grange. I won't bore you with the details, but it's a new agent that we can use in CKD, and it's quite effective. There is a risk of hyperkalemia, but a bit lower than spironolactone. So, okay, reducing albuminuria or protein in the urine. There's 4 drugs that we have at our disposal. ACE and ARBs, which if we're not using ACEs, ramipril, but any of the ones that end in pril, then there's something wrong because that is our Kimberley standard drug list agent. This is probably less applicable to you guys in the room, but there are lots of agents that we kind of come in, do a clinic like I was at Luma, chime in with, hey, have you thought about this agent because this patient has heavy protein in their urine? If we can reduce the protein in the urine, then we can improve their kidney function and reduce the rate of deterioration. And then optimize blood pressure. So again, low-hanging fruit would be lifestyle, diet, advice, physical activity, all that sort of stuff. And then there's a few different agents that we like to prescribe to get blood pressure down. Some are renal protective, like our ACEs and our ARBs. We love ACE inhibitors in renal medicine. Quite often we need 2, 3, maybe more drugs to get good control on hypertension with people with CKD. If you're at that stage, I would suggest that involving the nephrologist and even the local physician team would be helpful because there can be other underlying issues that we need to address. Again, that Bible has a little clinical tip that if you start these ACE inhibitors, the kidney function will drop slightly. And there's what to do if that happens, when's the threshold to cease it and change agents. So lots of little pearls of wisdom in that book and really, really helpful for clinicians. So if all that sounds very confusing and very overwhelming, we have a Kimberley Renal Service online service, on-call service rather, and that's the mobile phone number. Feel free to pop that into your phone if you need. It's answered by Hayley, Emma or myself, with 3 medical staff members of KRAS. Hayley covers Broome, Bidgedanga and the Peninsula. I cover Derby and surrounds in the Fitzroy Valley region. Emma is transplant queries along with Nick Corset, and the East Kimberley is shared by share amongst the team. It's a Monday to Friday service, 8 till 4:30, excluding public holidays. And outside of those hours, or for emergencies, we advise to go to Royal Perth Nephrology by switch.
Sorry, is that number for health professionals to call or for patients to call? For
health professionals, yeah.
Okay.
So what we'll be giving is as an example, so you're sitting in a clinic and you've got someone with you notice that has potential CKD or hasn't been, like, you're not sure if they've been identified as someone with CKD, you can call this number and say, hey, is this patient on your radar? And we can quickly look at them and say, yeah, or no, they're not actually. And then that can get the ball rolling for a referral. Or, hey, I've got this quandary of they're on this, this, and this, but I don't know whether to add this or up titrate this one. What do I do? We can answer that question. Or if they're at the late stages, hey, blood's looking really dodgy, and then we can liaise and be the link between nephrology and yourself on the ground. So we're there as a sort of a helping support. That's you. It's clinician to clinician kind of thing. So that's a bit of a background on CKD and how the burden on our population is and what we like to do and our goals of care. I hope that was relevant to you guys to a degree. Any questions so far? This is the halfway point. Yeah.
Just a couple. That's quite shocking to me, just how prevalent that is.
Absolutely.
If you'd asked me before this, I would have thought diabetes would be more prevalent than kidney disease. Do you think it's anything because of the level of toxins that we expose ourselves to? So, I mean, alcohol is obviously the big one, but that interaction of things like alcohol, vaping, smoking with a lot of people taking the medications much more often, people just popping paracetamol like it's Smarties, as well as processed food, detoxifying that, just the pressure that our kidneys are under now with the level of toxins we're exposed to.
Yes and no. So there's a few different things at play. Alcohol actually doesn't negatively affect your kidney function. It's a bit of a misconception. It has indirect effects on your kidney. So it's the liver function that is affected, and then we've got the renal syndrome sort of thing. The byproduct of alcohol is it dehydrates you and causes acute kidney injuries, and we know repeat kidney injuries is what causes CKD. So it's not like by the book. People think that, because when I go to clinic, patients they go into shame mode, like, oh, I don't drink that much, or I don't drink at all, and I've got CKD. Everyone thinks I'm a booze hound because I've got CKD. We have to explain it's not actually. It's a whole lot of things. Some of the things you've alluded to. We can get ibuprofen off the shelf, and we know that if you're dehydrated and you're popping ibuprofen left, right, and centre, that can cause an AKI or acute kidney injury. Our diet, particularly in remote and rural settings, is highly processed. Not much fresh fruit and veg. A lot of patients, it's so easy to just get a cup of noodles for lunch, and we know that there's lots of hidden nasties in that, along with the carbohydrate load, and then that affects diabetes. I mean, if we could eliminate, excess sugar from our diet for all these people and in society in general, the whole country would be a whole lot healthier, but we're addicted to it. We love sugar. That's part of, we all have a bit of sweet tooth. So it's a combination of a few different things you've rattled off there. Unfortunately for Aboriginal people, they're kind of on the back foot to begin with. So there's more and more research that there's what we know as epigenetics, that we know that these patients are born with less nephrons and less functioning kidneys, which is absolutely staggering. And it's through, mum and dad have mild to moderate CKD, and I inherit mild to moderate kidneys with poor function. So it's like an epigenetic thing. So you're already on the back foot, and it's still being worked out and still being researched, but we think that's why our Indigenous population have such poor health outcomes with CKD, because of this intergenerational passing down of genes with kidney functions that are not so great. So you're already on the back foot. But to come full circle, medications, if they're the right ones prescribed, taking them is actually going to be beneficial for your kidneys if they're on the right stuff that we've rattled off very quickly. But yeah, it's the over-the-counter stuff, and mainly diet. Our diet is playing a really big part of it. How much Coca-Cola goes through these sort of shops in the remote Kimberleys and stuff is outrageous. Yeah, I hope that answers your question.
No, it did. Thank you. And sort of from where we're at, so the students have been up doing a free pop-up clinic at Room Circle, and we've also been up in Derby as well. And when we do an initial consult, we always take someone's blood pressure.
Yep.
And so the students have had lots of questions like, oh, this person's blood pressure is a bit high, and we're always listening for other risk factors, and even like you mentioned. So at what point should we be considering this person needs to be screened for their, because we obviously do the blood pressure check, but then when should we think, right, we should maybe suggest this person goes to a GP to get that blood EGFR and maybe then ACR?
It's tricky, but essentially any of the risk factors from that initial screen, diabetics, people overweight, people who are over the age of 18 and Indigenous, because young people don't have high blood pressure, that's a bit of that's unusual. Any of the other ones that we rattle off, smoking, vaping, history of AKIs, family history of CKD, any of those risk factors, which I'm happy to go back to quickly. Who was it? There you go. Anyone with any of those? I think the short answer is most people should just pop in and get a kidney check.
But with their GP do that?
Yeah. Yeah, so we're spreading the word and we're trying to encourage people to do just the simple kidney check that we've described. But if you were to refer them, you would say this person has risk factors for what we think, has high blood pressure and risk factors for other comorbidities such as CKD. That would probably prompt your primary healthcare provider, your nurse or your GP to do, hopefully, these tests.
So you obviously know a lot about it, and at Kimberley it's so prominent, but these guys are going to graduate into this year and go wherever. I'm just wondering if they're going to have the same people that are as split up as yourself in the current sort of guidelines of all of this.
Potentially. The resource that I was alluding to before is a Kidney Health Australia. So it's not specifically for the Kimberley, although we lean on it quite heavily. It's for everyone.
Yeah.
So hopefully kidney health is sort of in their mind to a degree, and this is a very easily free available resource. So I would hope that they would at least think about it somewhat, because it is prevalent throughout Australia. It is rampant in Kimberley, but those stats at the start were nationwide statistics.
Yeah.
So hopefully it's on them. Not sure, but I hope.
Thank you for answering that.
Any other questions before we move on to the dialysis stage? I mean, it's pretty heavy for whatever o'clock in the morning it is. So sorry about that.
Would you rely much on questionnaires? There's a questionnaire, I think it's called SNAP 21, on those topics as well. Would you rely much on providing questionnaires for potentially chasing that further on as well?
So for chasing CKD as a screening tool?
Yes, screening.
Oh, look, there's
SNAP 21.
Yeah, there's many ways to skin a cat. I mean, everyone's got a different way to do things ever so slightly. I don't mind SNAP 21. I don't mind we've got we're developing one that pretty much plays off this Kidney Health Australia handbook. We're developing one that's very digestible, and 21 questions, isn't it? We don't feel like your patient's taking the exam.
Yeah.
So we've kind of whittled it down to sort of 3 or 4 things. Do you know about this? Do you have this? Yes, no, I don't know. Do you have this? Yes, no, I don't know. And that's 3 or 4 things, the big hitting items. And then we can go, yeah, I reckon you've got a CKD flavour about you. Let's get you linked in and sort it out. But yeah, SNAP 21, it's a good one, but can feel like if I took that to Luma, for example, people feel like I'm taking a test and they'll probably go, I don't go back there, you ask too many questions. So you got to dial into your clientele and who you're sort of delivering this message to.
You were talking about kidney disease with preserved EGFR modality. Is there differences in what causes that, or is it more due to patient genetics?
A little bit. So if it's a glomerular disease, so the issue within the glomerulus itself and the protein leaking out is the main issue. You can have that preserved kidney function up to CKD from the heavy protein in the urine. That's a different phenomenon to diabetic or hypertensive nephropathy, which is the whole nephron as itself. And that's what we're used to. So if the whole nephron's affected, then your EGFR will drop down. Or if you catch them later, the EGFR will be down. If you catch them early, that's usually when the EGFR is preserved. And that's where a lot of the cases are missed. So that people look at their UEC and go like EGFR greater than 90, job done, tickety boo, on your bike, see you later. But when you get an ACR above 30, that should be the point, well, above 3 really, because that's micro. But anyway, if you get an ACR that's above 3 or 30, which is really bad, that should be acted on. But a lot of people don't know how to interpret ACRs. They get it and they go 30. I don't know, is that bad? And that's when we miss the boat, and people can keep going through their lives, not knowing about their CKD, not making changes, and then all of a sudden, once they do get that drop in EGFR below 60, oh, well, you're stage 3A or whatever, you know, like now all of a sudden you're halfway down the chart, and it's new, you're just finding out about it. You know what I mean? So that's the thing I want you guys to take home is it's just because the EGFR is greater than 90, there's other things to look at. It's only 50% of the assessment.
So, and these changes you would start seeing them in like the blood tests from the start of the disease progression, or
can be nice, can be early. It can be quite insidious, and then because there's this phenomenon called hyperfiltration, so the kidney reacts to the CKD and tries to compensate for it, which bumps up the EGFR and hides itself. But what it's doing is by doing that, it's wearing out its kidney function a lot quicker. So it does this sort of compensatory thing for a while, and then all of a sudden it runs out of compensatory capacity, and that just the decline goes down.
Is there any way to identify those people, or you just wait until it's just masked until it's not?
Well, like I said, that graph there is how we work out the risk factor. So doing a blood pressure, doing an EGFR, and doing an ACR, that will put this graph into full perspective. So you've got your UEC on the column here, which tells you which row you're in, and then your ACR will tell you which column you're in. Pair that with blood pressure checks, then you've got a risk stratification. So you can catch someone nice and early, CKD1, you can go, hang on.
So it's similar to cardiovascular risk score, where you're trying to manage the overall risk sometimes instead of identifying the disease and just free from that.
Because by the time you identify it and the patient presents to you symptomatic of CKD, it's often too little too late. They're way down the track.
Okay.
And how often do you actually test them? Is like weekly, monthly? Because you said it had to be 3 months or more.
Yeah.
So
if someone pops in with like an illness and you notice a drop in EGFR, then you would recheck them within a 3-month period, whether that's next week, next fortnight, next month. As long as you get trends are your friends, is basically what I say to people when you're dealing with CKD. As long as you've got data to show that their EGFR, their kidney function is on the improve and return to baseline, job done, happy days that we've got out of the woods. But if you do that repeat follow-up and it stays low, that should pull the trigger on looking into, okay, you might have CKD, we need to do a bit more work here and work you up.
Thank you.
Yes.
Are you seeing up here in Kimberley, because, you know, there's the population that we've been speaking about mostly, you know, people who have diabetes or on the way, high blood pressure, blah, blah, blah. But there's also the other population that is sort of appears to be atypical, fit, healthy, does everything right. We have a protein store that's opened in Broome. Everyone goes, oh, I need protein because I'm exercising, and they're mildly dehydrated living in Broome. Are you seeing many people from the, I suppose, physically active population presenting or being identified?
If you take supplements,
I suppose in Perth.
yeah,
I'm an exercise physiologist.
Yeah.
My concern is that so many of my clients come and say, oh, I'm taking all these protein supplements. It's like, you don't need them.
No.
For what you're doing. And, you know, then, oh, I'm not drinking this much. I was like, you know, you need to be drinking a lot, you need to be having fibre. Oh, no, I'm not doing that. Well, you probably need testing, but are you seeing presentations?
Not really. I mean, the supplemental protein market, you're quite right, is booming at the moment. But it's like taking multivitamin. If you're eating a well-balanced diet, you're just making expensive urine. But in terms of overdosing on protein supplementation, you have to be taking a lot of it, like a lot. And proteinuria is not a matter of like an overflow kind of phenomenon. There's actually damage to the kidney that's letting proteins get leaked into the urine. So if you don't have,
it's not going to come from the dehydration as well.
Oh yeah, so if you dehydrate yourself, and you're talking about like bodybuilders and stuff.
I'm talking about so many people come to me and, you know, they come to me and start with some resistance training, they'll be, oh, I'm getting stronger. They then hit the protein shop. I then go, well, look how much you're drinking. You're actually not drinking enough water. And, you know, in the long term, because it's different to being down south when where you're not dehydrated during the time.
So that has the potential to turn into nastiness for your kidneys through the simple fact that we know, like we said, dehydrating causes acute kidney injuries, repeat kidney injuries equals CKD. So yeah, there's a potential for that to happen via that mechanism. The initial part of your question was, have I seen that rise of late?
Yeah.
Not really.
Good.
But there is potential risk. Yeah. All right, I might move to the dialysis section, and I'll try to keep it really, that was a little bit more detailed than perhaps the next part. And referring, this is an important part. So some of the things we refer to the nephrologist or indications: rapidly deteriorating EGFR, more than 50% over 3 months. Our First Nation Australians would benefit from an earlier referral. Basically, the nephrologist take over when the EGFR hits below 45 with really bad proteinuria, sustained decrease in EGFRs, and taking lots of agents to manage their BP. I would suggest that refer to the nephrologist. It doesn't hurt, even if they see them once and go, nah, you've figured out what the cause is, you're doing all the right things, discharge from clinic. That is such a good outcome and worthwhile doing. So when you get to the point where you're referring patients, refer them early. For KRS, it's a 2-for-1. Hey, how good is that? So you refer to KRS, the nephrologist and KRS team triage, and then we put them in streams. They'll either be in the primary care stream, which I will be a part of with Hayley and Emma and everyone, or the nephrology stream, which the specialist will take over, and we're kind of their hands on the ground. So by referring to KRS, you get a 2-for-1 thing. So the email address is on screen, krsAdmin@kmc.org.au. Do not refer to central referral services because Royal Perth will reject them. They want to keep them all in your house in the Kimberley. Otherwise, you end up with a patient from Yakanora, end up with an appointment in Godric Street. You know what I mean? Like, just logistically does not work. So you want to keep them in the Kimberley. So referring to KRS, we'll refer to nephrology at the same time when we triage them, okay? And then we'll keep an eye on them. They're at least on our radar. What do you need for referral? MMEX, which we use, has a template from their section. You'll be easily find. Otherwise, if you're not working with a place with MMEX, just a generic template's fine. All the recent pathology and investigations, an up-to-date medication list, a recent ultrasound, kidney, ureters, bladder. Now that's excluding obstructive and structural issues, because that's part of working out what the etiology of kidney disease is, right? So if we know that there's an obstructive issue, then the nephrologist will handle it to urology for starters. But if it's a structural issue like a polycystic kidney disease, they go, there you go, there's your answer. No more, you know, we know the etiology, we can fix that. And also relevant past medical and family history. So that's your kind of your checklist. If you've got those 5 things in your referral, we're happy as Larry. Okay, so approaching renal replacement therapy. So the frequency of renal checks increases in late stages, so 4 and 5. Blood pressures and weights are super helpful because at this point in time, usually their pathology is just out of whack. The little brackets with reference into on the platforms is useless by this stage because kidney disease, the units and what we're used to seeing as normal, quote unquote, is very different to what the rest of the population is like. And essentially their pathology can look absolutely woeful, but because they're compensating, they go, I feel fine though, I feel good. So pathology is hard to rely on unless the EGFR is like 0 or 2, then you go, you need dialysis. So the pathology is less reliable because of the compensation and patients get used to feeling rubbish. It's more the symptoms that they're feeling and their blood pressure and their weight. If you stack on 10 kilos of weight within seeing them within the week clinic, you go, holy cow, you're hanging on to all that fluid. The time is now. So blood pressures and weights every time you see someone with CKD, really, really important. So often we go to review someone, we pick up the phone and I'm really worried about this person, they need to start dialysis. What was their last weight? Oh, 2023. Not so helpful. When was their last blood pressure? 6 months ago. Not so helpful. So really good to get that really simple, easy, low-hanging fruit in there. Hopefully, by the time they're 4 or 5, they've discussed options of their renal replacement therapy. And the 4 options are satellite hemodialysis, which is where I step in as part of the renal GP team. Home hemodialysis, which is a bit of a funny name because usually the home hemodialysis is attached to the clinic, like Bitchdanga, Balls Creek, and all sorts of stuff. There's peritoneal dialysis, which you can do at home. Lots of independence, but really strict criteria because the risk of getting infection in the peritoneum and dying from it really high. You need to store all your materials. You need to be pretty good dexterity with your hands, fiddly with the weighing and the bag changes. Good eyesight so you can read the bag and have some form of health literacy. So not everyone is a good candidate for PD, but we try and get them to keep them off machines. And then there's the conservative pathway. Lots of patients, when I say conservative pathway, think that we go, you've got CKD, you're going to die from it. Okay, see ya, bye. Not the case. We would still see them like any other patient. We would offer them medical support and management. We would weigh in, we would help with their symptoms. But the only difference is when they get to the point where things are getting dire, we have a goal and a ceiling of care, and we respect that. There's lots of elderly people in the back of the Fitzroy Valley who have no interest in moving, have lived there their whole life, don't want to go to Perth, don't want to do this. I know I'll die from it. I don't care. I want to stay here. And we respect that. Because dialysis is hard work. You wouldn't wish it on your worst enemy. It's really, really taxing mentally and physically. So we respect conservative pathway management if that's what the patient wants. And it doesn't mean we just cast them asunder and say, good luck with your kidneys. No, we are still involved in that care. I see a lot of conservative pathways when I go to clinics. Things to consider, obviously, if someone is going on to satellite dialysis, they're going to be exchanging blood on a machine. Risk of bloodborne virus is really high. Think about hepatitis B vaccinations and their status, immunising them if they get into that point, at least asking the question of their serology and things like that. If you see a young person who's on dialysis and they've got really bad anemia and you're in ED, because I used to be that person, you go, oh my God, their hemoglobin's 60 and it should, normal is above 100, so 110, 120. Oh my God, the hemoglobin is half of what it should be. Get them a unit of blood. Pull back on that thought if you've got a young person on dialysis, because we might be working out for a transplant. You start putting them with units of blood, you're priming their immune system to reject a graft. So lots of people get a decision of transfusing the blood. It's not the end of the world, but we want to avoid it. We've got lots of things we can do otherwise. Iron, we can do EPO, there's lots of things that we can do. And it's probably chronic. The patient's sitting there going, yeah, I feel a little bit tired. No big deal. It's been there. It's been that way for ages. You don't need to fix it right here, right now, even though the number is screaming at you on the screen. So yeah, it's usually a chronic issue. If they're having a bleed and it's in their boots, they need it. They need it. We don't say, well, you don't get the transfusion. But just think about it in terms of, is it a chronic issue? Can we do other things? Can we avoid that transfusion for immune priming? Fistulas. Okay, here we go. We're getting somewhere. So arteriovenous fistulas are joining in the artery and the vein to make a big line of the vessel to plumb into when we go to dialysis. There's 3 main types. There's the radiocephalic, which is down the wrist. There's the brachiocephalic, which is around the elbow, and the brachiobasilic, which is up tucked under the armpit. So we work hand in hand with the vascular team for those 3 types, getting them sort of teed up for it. We'll do mapping, ultrasound both of their upper limbs to find out which is the best, straightest, widest bore vessels to work on. And then they go in for an operation and have the 2 joined together. Takes about 6 to 8 weeks for it to mature, so you can't just have that operation, stick a needle and dialyze them. It still takes time. So there's a lot of prep work with end-stage CKD and that, making sure the patient's ready to start dialysis. If dialysis is commenced prior to the fistula being matured or placed, they have a CVC. I'm not sure if that's a good picture, it's a bit grainy, but essentially it's a tunnel catheter that goes from their chest wall up through the superior vena cava into the right atrium. And you can see the tip of it just sitting there in the right atrium. Obviously not the best, high risk for dislodgement, high risk for infection, high risk in all ways, shapes and forms. You can't go swimming with it because you can get an infection in it. You've got to keep it covered if you have a shower. So yes, very, well, last minute sort of crash landers will have a CVC basically. Fistulas, they look weird sometimes. Usually if they've been, as I like to say, flogged out. So that is from someone cannulating the same spot day after day, year after year. You can look like an anaconda sitting on your arm. People ask me, how do I examine a fistula? Just look, listen, feel. Just keep it nice and simple. So look, if it's a new one, look for the surgical scar. It'll tell you where it should be, and then you can focus your attention there. Looking for signs of infection, redness, swelling, ooze, all the cardinal signs that you're aware of. Does it look aneurysmal? You can see the flash on the camera has made really good example of where the area of skin is shiny and thin. That's a risk of rupture. That's one and if it ruptures, there's a litre a minute going through there. So people will exsanguinate to death very quickly if they do crank. It's a medical emergency and we take it very seriously. So looking at it, that's the sort of things you're looking at. Listening, there should be a bruit. Now, bruits are bad everywhere else in your body. You shouldn't be a bruit. Oh, no. But because it's an anastomosis of two vessels, there's turbulent blood in there, and it's normal. You should hear it. So it kind of has, if you find a dialysis patient, put a stethoscope on their fistula. They don't mind. And you hear what they sound like. Quite interesting. If you hear a high-pitched whistle, that could mean stenosis, because it's a narrowing of that vessel. So if you hear whistling over their fistula, bad news. If you hear nothing, worse bad news, because it means the fistula is all of a sudden clotted or failed. And that's their lifeline to dialysis. That is, you're on a plane, you're down to Perth, you're getting a new line straight away. So if you hear weird stuff, it's probably normal. If you hear nothing, it's bad. And if you hear high-pitched stuff, it's bad. And then feel. You should feel a thrill. So when you put your hand over a fistula, you should feel that turbulent blood mixing together. It's like a vibration. It's like a little buzzy bee, you know, in ED, the buzzy bee, when you do cannulations on kids. You should feel like that, just humming away. Again, a lack of a thrill is bad. If you don't feel that, could be clotted, could be failed. And if you feel a bounding pulse in a new one, like a really strong bounding pulse, it may mean it has not taken, it hasn't matured, and it's failed.
So the turbulent blood flow, is that because you've got like high connecting to low pressure? Is that
correct? Yeah. Okay. So the high arterial pressure mixing with the low pressure venous blood mixing together and coming back to the circuit. Yeah, totally. It goes without saying, but please, no blood pressure cuffs or bloodletting on the side of the fistula. It just reduces any risk. I mean, push comes to shove, you can, but we prefer not to, because, you know, if you tourniquet above that, then all of a sudden you've got this more pressure on something like that. You go, oh my gosh, you know. Commencing dialysis, when do we do it? Well, they may have all of these symptoms, may have none of them. It's more of a syndrome. So they might be short of breath, they might have all the edema, they might have ascites, loss of appetite, nausea, vomiting, fatigue, brain fog, confusion, all the way up to coma, pruritus, so feeling itchy skin, muscle fatigue and cramping, and headaches secondary to hypertension. Basically, we start dialysis when they've got refractory hyperkalemia, severe hypertension, deranged electrolytes, severe acidosis, fluid overload, or uremia. One of those things that are severe is enough to pull the trigger. We just keep an eye on all these things. So, logistics of commencing. This is what usually makes people get really sad, and it is sad because it's quite harrowing for the patient. So, I come along, so you need to start dialysis. Yeah, okay, it's been a long time coming. What do I do? Well, you now need to leave your home and community, possibly for the first time ever. PATS generally does not allow escorts when it comes to starting dialysis, so you're going down solo. You land in Perth, you get plonked in a busy tertiary ED. There's all sorts of weird and wonderful things that will not look so wonderful. Really high energy environment. It's quite scary if you're not used to, if you're only used to a small clinic in a small remote community, then a tertiary ED is a hectic place that's really confronting. If you crash landed, you'll go and get a CVC, you'll commence dialysis under the watchful eye of the nephrology team. They start with low pressures and low hours and build them up to a usual 4-hour plus session twice weekly. Because that's such a huge amount of stimuli and to get your head around, and it can be quite harrowing for patients. There's 2 services we use, Country Connect and Country Parts. They coordinate supports, assist with accommodation, linking with relevant services such as the ALOs, and Country Connect is particularly good for holistic, culturally appropriate cares when they're in Perth. So linking them into there while, you know, in lieu of not having an escort or a support person is the least we can do for our patients, and we try and get them linked in. You generally spend 3 months in Perth under this observed dialysis for fine tuning. Sometimes PATS will allow you to have a support person at this stage, but you're generally an outpatient by now. So you're coming, going to hospital, making your own way there via bus or taxi if you've got money. Or that's where we get the country pass. They can help give you a lift. That's really helpful. You sit there for 3 months in Perth when it's cold, miserable and raining, freezing. You probably don't own too many winter clothes because you're from the East Kimberley. Waiting for a seat to become available at one of the units. Now, if they're full and there's no seats, we're literally waiting for someone to die to take their spot because there's no more chairs, which is really sad. If you have ongoing issues with your dialysis, the wait time can be extended way beyond this. There's one lady that's been down there for 18 months waiting to get herself sorted out to come back. They're still working on it. Some patients will opt to discharge to larger dialysis units awaiting their preferred location. So what I mean by that is, I want to dialyse in Cunningham. There's no room in Cunningham. It's a spot in Derby. Okay, I'll go to Derby for a bit, and then I'm first on the list to go to Cunningham when the spot's available. So that's a temporising thing. At least people are back in the region, and they can be on country somewhat. Fitzroy Crossing takes a lot longer because there's only 4 chairs out there. However, an expansion has begun and there's going to be 8 chairs out there. So we're going to be able to get a lot more patients home, which is going to be great. If you are compliant with your dialysis, you do the whole sessions, take your medication, you live a healthy lifestyle, you don't drink, you don't smoke, you do the right thing, you might be worked up for a transplant. But on average, that takes a couple of years to work you up and make sure that you're the right person for the graft. That's a whole lecture on itself, transplantation, and I'd be happy to come back and talk about that. So where can I dialyse in the Kimberley? So where the 4 little kidney beans are there our locations. Down the bottom, Broome, where we are. Next one above it is Derby, to the right, Fitzroy, and above that, Kununurra. I look after Derby, Fitzroy Crossing, and all the areas of CKD in between. Hayley does Broome and the Peninsula and Bidgie, and then Emma up here in the east. So, Broome, 10 chairs, Derby, 13 chairs, the biggest unit, Fitzroy, 4 chairs, going to be 8 in the foreseeable future, and Kununurra, 8 chairs. So, types of hemodialysis. I started looking into this, and it's the origins are from Greek words. I just thought of the guy from my big fat Greek. For come from the Greek, the word dialusis, meaning dissolution. So dia through lucis, loosening. So although we say hemodialysis as a catch-all, it's actually hemodiafiltration. So put very, very simply, hemodialysis is just using osmotic and diffusion gradients. One passes through, high concentration, low concentration, exchange happens. That's dialysis. That's a really, really oversimplified version. Does good for small molecules, but big molecules like phosphate, not so good because concentration gradients are hard. Hemodiafiltration is that same osmotic and diffusion gradient phenomenon with oncotic or countercurrent pressure. So we're pushing the fluid through as well, which creates that oncotic drive for the bigger molecules. In theory, it's a better form of dialysis. All of our satellite units use HDF machines. That's essentially how it works. And this is a really, really, really basic mind map of it. So it says saline solution. Ours are plumbed to the wall, so we've got it from the mains. So water comes in, it's heparinized so the circuit doesn't clot. It goes into the dialyzer where it joins the other 2 circuits. So from the patient, their old blood comes through, it's pumped through the dialyzer, which is the artificial kidney per se, and comes back into the body. Then we've got the dialysate, which has concentrations of different electrolytes that we can titrate and fine tune. It comes in and there's countercurrent. So you've got the diffusion gradient from the concentration in the dialysate, as well as the push and the drive countercurrent. So you can see the 2 arrows and try and demonstrate the countercurrent. That's a really, really simple version of what a dialysis machine is doing. They're obviously a lot more technical than we can fine tune things, but essentially that's what's going on. So what does dialysis remove? Extra fluid, nitrogenous waste, creatinine, urea, potassium, phosphate medications, all the good and bad stuff. So we've got to really be careful what we take out. Fluid removal, this is how I want you to think about it. It's probably a little bit technical, but bear with me. So you've got the dialyzer, which is a set space, the vascular space, which is in your blood flowing around, and then the extravascular space. And that's when we hear about people having fluid on their lungs, in their tummy, in their feet, on their face. We really want to get rid of the extravascular space stuff, but we can only get to it by the vascular. So brace yourself for the most primitive animation on PowerPoint you'll ever see. So you chuck the patient on dialysis, you get rid of their vascular space, and you go, woohoo, blood pressure's improved, and we got rid of a bit. And then you go, job done. Not really, because then they refill from the extravascular space and top themselves straight back up. So that's why they come to dialysis, we do the right thing, they get back to ED, they go, blood pressure's still high again. Well, they've refilled. So what we're actually chipping away at is the third space, but we've got to go via the two other spaces in a roundabout way. If we take too much fluid at once, it can be trivial things like the patient cramps up, they feel uncomfortable, which is not good. We don't like it, so we try to avoid it. But all the way up to hypovolemic shock, hypertension, arrhythmia, and sudden cardiac death. How do we overcome that? Well, we get them to come in for regular dialysis. We do full sessions and we do a fluid restriction of 1 litre a day. Up here, 1 litre a day is hectic, particularly when it's really hot and humid. Imagine how thirsty you are for being outside all day. You come in, you smash a bottle of water. That's your fluid done for the day. No more for you. That's it, you're done. So we end up in this big vicious circle. So you get big weight gains, big volume shifts. We take more off on the machine. They end up being hypertensive. So they get a bolus to bring them up. Otherwise they're flat and, you know, not conscious. And then if we take big volumes off, that activates the thirst mechanism. So it makes the patients literally more thirsty. It's a survival mechanism. We've had this for millions and millions of years. Your low volume of your blood, you're thirsty, refill me. So we're taking all away. The thirst mechanism is really, they're screaming. Their brain is going, I'm so thirsty, get some water into me. And then round and round we go, big weight gains. We take big fluids off, thirst, bang, 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 round and round we go. So it's really, really hard. Lots of ED doctors, and myself included when I worked in ED, go, well, why is the patient here for high potassium when dialysis will fix that? Why don't you just put them on the machine? And I used to do this too before I did this job. But there's a phenomenon called rebound hyperkalemia. Essentially, if they got really high potassium, you take it off them in the machine, then they got really low potassium. And then just like the fluid, all the potassium in their cells floods into their blood. And then they get a really high potassium again. And that's what makes your cardiac membrane unstable and you get arrhythmia and sudden cardiac death. So that's why when we send a patient to ED with hyperkalemia, they go, dialysis will fix that, what the hell are they doing here? This graph of what I'm trying to demonstrate here is what we're trying to avoid. And that sudden shift, high, low, high, makes the cardiac membrane really unstable. And you can have torsades or VF or VT, any other arrhythmias pass away from it.
So what's the window of that?
Depends on the patient. So some patients are used to operating at 6 point somethings, which is high for you and I, they're normal for them. Other patients are operate at 4s. So we've got to look at what each one is. And if we've deemed them that they're high, but essentially we won't dialyze someone if that's over 7. That's far too risky.
Thanks, Stephen, we need to run.
Yeah, no worries. Thank you. So we mitigate this by doing gentle dialysis, repeat dialysis back to back, and slowing things down. So we're not denying dialysis when ED says that we are. We're mitigating the risk and making safe dialysis for the patient and the staff members. And when you get to ED and you've got a dialysis patient that comes in and they're fluid overloaded, and yeah, why don't you just go to dialysis? Why don't you just take the tablets? Why don't you just do this? Because I was guilty about working ED because you get fatigued and cynical. But remember, that's 12 hours a week that they're sitting there 3 times a week, sitting there on a machine. That'll get the best of people down. The hardest of people would have trouble doing that. So, I don't feel like doing dialysis today. I used to be like, well, I just dialysis. But now I see people, and it's really sad to see all these people sitting in machines for 4 or 5 hours. So go easy on them. And when they're drinking too much fluid, remember that thirst mechanism is like, yeah. But anyway, that's it. Those are the numbers that I want you to remember. And I think it's 8 o'clock on the dot.
Bloody legends. Well, that was really interesting. And I'm not even a doctor or studying. So thank you everybody that have tuned in. Really appreciate your support, and thank you, Dean, for doing that.
Were there any questions from online?
I don't know if that's on. We've lost all the Wi-Fi here. The whole rural clinical school's down, so I've been hotspotting off my phone. So that's why I keep checking it, because I've been paranoid it's going to drop out for this whole presentation. So
Yeah.
Thank you. I'm going to cut it off now.